This is probably the most important event, actually, because we're talking directly to people with MS. What type of research did we present at ECTRIMS 2022 that might have an effect several years from now on the lives of people with MS?
How often should these stem cells be administered to the patients to have a long-lasting effect?
There's a couple of mechanisms that we can target in order to produce repair, and I think the one that makes most sense to us intuitively is something that will regrow back myelin.
Welcome to part one of a three-part series on a special ECTRIMS event held recently for people with MS. I'm Naomi Smith, and you're listening to the ECTRIMS podcast. ECTRIMS is committed to ensuring the latest research on multiple sclerosis unveiled at its annual congresses reaches the people most affected by it. In a first for the world's largest MS research organization, a special ECTRIMS 2022 event specifically for people with MS was held on the 29th of October in Amsterdam, the Netherlands. During this free event, available on-site and online, and in several languages, MS experts discussed the key insights of ECTRIMS 2022. The event was chaired by ECTRIMS President Martin Torre and the local organizing committee chair, Bernard Oud-de-Haag. The following podcast episode is part one of a three-part series sharing the audio recording of the event. Listen to Mar and Bernard open the discussion, followed by an in-depth presentation by Dr. Daniel Ontaneda from the Cleveland Clinic about promising new midterm research data for people with MS.
Dear friends, my name is Martin Torre. I am a clinician working in the MS Center of Barcelona, and I am also a clinical researcher. I work with MS patients for my last 30 years, and since yesterday, I'm also proud to announce that I am also the current president of ECTRIMS. And together with Professor Oud-de-Haag, when we were organizing the scientific content of this year's meeting, we very quickly came up with the decision that we wanted to also organize an event for people with MS who had to be just after the meeting to deliver the novelties of this year's meeting just firsthand and directly to our patients and to our community. We think that this is an event that is going to be continued by ECTRIMS in the forthcoming years. We are also very conscious of language barriers, and for helping in this, we are happy to announce that this event is going to be translated simultaneously into the 6 main European languages, and this is, of course, a hybrid meeting. I would also, therefore, warmly welcome those of you who are here today. Thank you very much for making it possible to be here, and also to welcome those that are connected. This is very important for us, having you connected in the distance. So welcome, bienvenidos, benvinguts, soyez les bienvenus, benvenuti, et je ne sais pas d'autres, I don't know other languages. So Bernard will follow. And with this, I am sure we are going to have a very fruitful morning. And please, Bernard.
Thank you very much. And in Dutch it's welkom. Hartelijk welkom allemaal bij deze mooie gelegenheid. En ik zal vast zeggen voor de mensen die... u krijgt de vertaling in het Nederlands als het goed is, maar mocht u vragen willen stellen en dan is de taal geen barrière, dat is misschien mijn barrière. Stel de vraag gerust in het Nederlands en dan ga ik dat proberen te vertalen. Now I'll switch to English again. So that was my warm welcome also for the Dutch people here in the audience, and that they were allowed to ask the questions in Dutch if they prefer. And it's now my pleasure to introduce the first speaker. And unfortunately, I have to say that you may have seen that Professor Elga de Vries was on the program, but unfortunately he couldn't make it. So therefore, there's only one speaker in the first part, and he is also covering the part that Elga de Vries was. So we are very happy that he is willing to do that. It's Dr. Daniel Ontaneda, and he is a associate professor of neurology and in the Cleveland Clinic Mellon Center of MS. So thank you very much for being here, for being able and willing to present with this difficult, very difficult task to try to communicate what has been said in the past 3 days, just in a short period of time, and also trying to select things that could be having the influence in clinical practice, which is the second hard thing to do. So thank you very much for being willing to do that.
Yeah, thank you so much for the very kind introduction. And also I would like to congratulate both of you on organizing this event, because I think it is, when I got invited, I said, wow, this is probably the most important event actually, because we're talking directly to people with MS. And that's quite different than what we typically do in these scientific meetings, when typically it's a meeting of scientific and research peers. But I think communicating this back to patients is of utmost importance, and it is a challenge to cover 3 days in 10 minutes with slides that are not my own and that I was just looking at for the last several minutes. So of course I am not Elga, you guys have been downgraded, but I will do my absolute best to try to move forward. All right, so we start out with this figure, which might be or might not be familiar to some of you, but this is a cross-section of a brain. And on one side, we have a brain of an individual, a cartoon of an individual who does not have multiple sclerosis. And on the other side, we have a cartoon of a person who does have multiple sclerosis. What this demonstrates is that there are these small areas that are deep within the brain, typically surrounding the ventricles, which are these fluid-filled cavities in the middle of the brain, which we called MS lesions or MS plaques. They are also in the depth of the white matter. That is where predominantly we see lesions in multiple sclerosis, but they're also in a different part of the brain called the cortex, which is underlying the surface of the brain itself. And many times what we're trying to do is we are trying to investigate what is happening in these lesional areas in this plaque that might inform why multiple sclerosis is occurring and perhaps how we can better treat the disease. Certainly outside of just changes occurring in the lesions themselves, we know that brain tissue, when you look at it, would look potentially normal. We know that when we look under the microscope at that, what we call normal appearing tissue, that tissue can also be abnormal, and that also might inform how we better understand the disease and we can better treat it. So this is a review. It's a little bit of a busy slide, but it basically overgoes what are the different treatments available for multiple sclerosis and where they're working. And when we think about treatments for multiple sclerosis, we can think about them working in two different places. One in the peripheral system, that is in our blood, and the other is inside the brain. So first I am going to cover the treatments that cover the peripheral, so those medications that work in the blood. Multiple sclerosis is an inflammatory disorder, and inflammation in inflammatory cells are typically carried from the blood into the brain. And therefore, if we can affect inflammation in the blood, we believe that we can abrogate multiple sclerosis, and we have multiple clinical trials that have shown that if we modulate the immune system on a peripheral basis, we can actually help individuals with MS, prevent the formation of lesions, prevent relapses, and actually try to decrease the accumulation of neurological problems over time. So just briefly, we're going to go over kind of what these medications are. I would say that there are medications that are generally acting on different types of immune cells, and some of these act quite broadly. Medications such as alemtuzumab, which actually depletes both B cells and T cells that we know are players in MS. Then we have medications that we call anti-B cell therapies. These are medications that just act on B cells. Very different to medications that act on both. We previously thought that the main effector of disease in multiple sclerosis was the T cell, But when we approved therapies and when we tested therapies that acted on B cells and they did as good or better job sometimes than medications that affect T cells, we knew it was a disease that affected both. There are then medications that have been a little bit more designed specifically for MS, such as natalizumab. Natalizumab doesn't deplete cells. What it does is it does not prevent cells from entering the brain, so it's a different mechanism. Other medications, such as the sphingosine 1-phosphate receptor modulators, are medications that actually keep these blood cells in our lymph nodes. It doesn't allow them to get into the brain by trapping them, if you like, in the lymph nodes themselves. And then certainly there are other partially depleting medications, including lecanemab and other medications. Teclistamab is actually a medication that is not currently available for use, but it was a medication that worked on a specific type of natural killer cells in the periphery. So let's move on to think about how these medications might work inside the brain. And so we know that some of these medications actually get into the brain, and once they're in the brain, they might have effects inside the brain. So we think that natalizumab certainly will not allow these medications to enter. Medications like glatiramer acetate are medications that probably work in a combination of peripheral and central mechanisms, and what they do is they make these T cells that might have an inflammatory profile or a non-inflammatory profile, shifts them more a little bit to the non-inflammatory profile. And then some of our medications actually have work on the nervous cells themselves. They work on pathways that are related to how well neurons might survive. And we have other medications certainly that we're looking for that might be able to regrow myelin. These medications are not currently available, but the idea of being able to regrow myelin is something that is in the horizon. So now going on to more kind of what was presented at the meeting, you have already seen this picture of an individual, one brain with MS and the other one without. And we know that there's a number of different types of lesions in multiple sclerosis. And although that we call them lesions somewhat generically, if we look under the microscope, many of these lesions have different profiles. There are lesions that are active, and those are lesions that are likely in formation, and they have a combination of inflammatory cells that are both new and old. Then we have lesions that the presence of these inflammatory lesions has gone away. There's no acute inflammation in there, and it's kind of what we call an inactive lesion or a chronic inactive lesion. And then we have some lesions that are chronic, they're old, but they have a combination of inflammation and not. And then we have sometimes lesions that were present, they were probably actively inflamed at one point, and then myelin regrew in these lesions, and they're basically something we call shadow plaques or remyelinated lesions. Now, the interesting thing is that we've developed technologies so that we can actually use microscopes at very high resolution to capture individual cells from each of those lesions. And this is important because up to now it's been hard to study these, because many times when we do genetic analysis, we do genetic analysis on a large variety of different cells. So if I do a genetic analysis I just pick a lesion, it will have multiple different cells in it. Now technology has developed to a point that we can actually laser target individual cells and pick out specific populations so we can look at them. This allows us to understand much better what is going on in a cell. And so here you can see different maps of what these lesions look like with respect to any given marker. What this allows us to do, for example, here in this example, we're showing where there is mitochondrial activation across different types of lesions, normal appearing white matter active lesions, these shadow remyelinated lesions. And we can look at expression of different genes within those lesions, specifically within the cells of each one, to better understand how these are functioning. Well, what else can we do? We can also look and interrogate for different places in the central nervous system. So there is the opportunity to look at blood from patients. There's also the opportunity to look at the choroid plexus and something called the septum, which is a deep structure in the brain. And what these experiments that we're presenting here have shown is that there's a variety of different cells that we can take. So specifically in this study, what they did is they took this area of the brain called the septum, which we really hadn't thought of something particularly important, and also an area called the choroid plexus. And they were able to demonstrate that there's a variety of different cells coming in that region. And one of the important results of this study by Rodriguez-Lorenzo, which is actually already published, was that they found a special type of NK cells. And these NK cells are cells that we thought were bad inflammatory cells that were just in the periphery. And it turns out that these bad inflammatory cells are not just in the periphery, but they're resident in the brain. And this perhaps might mean that there could be a potentially new mechanism with which to treat the disease. Let's move on to lipids. There was a lot of discussed on lipids, and we know that structures such as lipoxin A, which is basically a lipid-derived product, might be different in MS patients and healthy controls. So when we study them, we find that MS patients have different levels. And what do we think these do? We think these cells actually are going to change how these inflammatory cells look. And so when we take this experiment and we actually take it to the lab, what we do is we take cells, which we call these T regulatory cells. And T regulatory cells are the cells that kind of keep inflammation at bay in our bodies. And we think that these T cells probably are defective in individuals who have multiple sclerosis. That is, they're not working as well, they're not holding back inflammation. And if we expose them to specific lipids, specifically in this case, this was an experiment done by the lab of David Hafler at Yale, they showed that if you express these T regulatory cells to oleic acid, they actually shift from having defective suppression to being cells that are less suppressed and therefore are going to hold back inflammation better. Why is this important? This is important because oleic acid actually can be sourced. It can be sourced in our diets. And what this paper is suggesting is that perhaps it might be a mechanism through which we can actually treat MS patients. That is, if we can supplement oleic acid through foods such as olive oil or sunflower seeds or avocados, perhaps we can take these T cells and make them less regulatory active. Now, by this, I am not saying that we should all go out and have gallons of olive oil. This has been demonstrated in the lab, but of course, this will have to be confirmed and studied in patients and people with multiple sclerosis. All right, and that is the end of Professor de Vries' presentation, and now I will move on to my own presentation, and then maybe we can do a discussion. All right, fantastic. So I'm a little more familiar with these slides, but maybe I will be even less clear with my presentation of them. These are my disclosures. So I was asked to talk a little bit about midterm. What type of research did we present at ECTRIMS 2022 that might have an effect several years from now on the lives of people with MS? And what I elected to do was to present data on new developments in clinical trials. Clinical trials is something that is dear to my heart. That is basically the majority of the time my research is dedicated to clinical trials. And I'm not sure if anybody is familiar with this picture, but we think about trials occurring in different phases. Many of the data that I presented early is the preclinical work. That is the work we do in the lab, such as the one with the oleic acid, where we make a discovery for the first time. Then we take these discoveries that are made in the lab and we put them into what we call phase 1 studies. Phase 1 studies will study a very small number of people just with the medication that we're interested in testing. Many times it's done in healthy controls. Sometimes it can also be done in individuals with multiple sclerosis. And the idea there is to make sure that the medication is safe. We really aren't testing it to see if it works. We're only testing to make sure that it is not toxic, that it does not hurt a person who is taking the medication. Phase 2 studies are a little bit larger. They're the next phase of studies. They typically involve between 100 and 300 individuals, and the purpose of phase 2 studies is actually to find the adequate dose we're going to use in individuals who have the disease. And of course, this is always done in individuals who have multiple sclerosis. And typically, what we try to do in those studies is 1, figure out what dose we're going to use, 2, make sure that that dose is safe, and then try to get an idea of how well it's working. So even though the main goal of a phase 2 trial isn't how well does it work, we focus on how well it works because we want to make sure that it's a medication that if we take forward to a larger trial, it's potentially going to work. If a medication is successful in phase 2, that is, it is safe, it's tolerated, we find a dose that works, and we see a signal that it's perhaps working well, we take them on to phase 3. And phase 3 are our definitive studies. These are our studies to decide, yes, this is a medication that I can use actually in clinical practice. The data from these phase 3 trials are actually submitted to the regulatory agencies. In the case of Europe, the European Medicines Agency. In the case of the United States, the Food and Drug Administration. And the medications are then approved based on the results of these phase 3 trials. And typically the FDA likes to see at least 2 large phase 3 trials in order to approve a medication. Importantly, in phase 3 trials, the outcomes we look at for efficacy have to be clinical. They have to be something that affects the feel and function of the individuals who are being studied. So many times in phase 2 studies, we might study MRI lesions, and I'm going to show you a couple of those. But in phase 3 trials, we have to study stuff that matters to patients, stuff that you can feel, a relapse, attack, how much disability are you accumulating, how much fatigue do you have, perhaps. And then finally, we move on to phase 4 studies. And phase 4 studies are the studies there. Once a medication is approved, we continue to do studies in larger populations, in more diverse populations, to make sure the medication is working appropriately. So the first study I am going to present to you is assessment. This is the result of a phase 2 study, and the assessment of dose dependency of anti-inflammatory and neuroprotective efficacy variables and biomarkers from a study of a medication called vidofludimus. And vidofludimus calcium was studied in a trial called Emphasis. And this was a randomized placebo-controlled phase 2 trial in patients with relapsing-remitting multiple sclerosis. I am going to break that down. You probably see this, a randomized placebo-controlled phase 2 trial. Randomized means that we use a computer to kind of flip a coin and decide if a person goes on the medication, in this case, vidofludimus, or if they go on a placebo. And what it means, phase 2, we've already discovered, we've already reviewed, that this is a study that is looking at safety and dose finding. And here what they're looking at is specifically here at what are the potential neuroprotective effects of this medication. Because in the phase 2 study, we want to understand, well, is there some signal that this is actually working? So what is this compound? It's also called IMU-838. It's basically a next-generation teriflunomide-like medication that affects dehydrogenase. That's a mouthful. I don't expect anybody to learn that. But what this medication does is it actually takes T cells that are actively replicating, and it doesn't allow them to replicate anymore. So it saves the normal T cells that are in your body, and it only takes care of the ones that are actively replicating. And therefore, it decreases the immune system, but doesn't completely suppress the immune system. So we want to limit its side effects. What are the advantages of this medication? Is that it's a daily dose, and also that there's no need for an elimination process. So the previous medication, teriflunomide, is a medication that is very good, but it stays in your body a really long time. And it is quite toxic if somebody wants to become pregnant. And so if we want to get rid of the medication for any reason, people have to wait months and months before the medication actually leaves their body, or we have to do a rapid elimination process with basically activated charcoal to get it out of the system. Now, we know that this medication will not have that problem, and therefore it's potentially interesting. So what was this Emphasis phase 2 study? It was a study that examined people with relapsing remitting multiple sclerosis who were 18 to 55. And to get into the trial, these individuals had to have somewhat active disease. They had to have a relapse, at least in the last year, or at least 2 relapses in the last 2 years. And these had to be individuals who were walking independently. What was the objective of the study? It was to examine if this new medication had an effect on new lesions or active lesions. That was the primary efficacy endpoint. And the secondary outcome, the other primary outcome, was to find the lowest effective dose of the medication that works. When we test these medications, we want to make sure that we use a dose that works, but we don't want to use the highest possible dose because there might be some toxicity associated. So we look at what is the highest dose of the medication that seems to work. Is there a ceiling effect of how high a dose you have to go? And also examine the safety. So this is quite typical of a phase 3 trial. So you have one arm of the study that gets placebo, that is a sugar pill, if you like, something that does not have any inert effect in our body. A group of the patients got the 45 milligrams of this new medication, and a group got 30. So they wanted to determine if the 30 or 45 was better. And what they did is, in order to make this trial actually attractive to people with MS, they said, well, if you're going to go on a placebo, why would you participate in a trial if you're going to get a sugar pill, which is a little unfair. So many times what we do in these studies is that we do a 24-week period where you get a placebo, but then all the patients eventually get on one of the other doses of the new medication. So a re-randomization occurs at this point, and then eventually all the patients are followed at the lower dose. So what were the results of the study? Let's look at the effect that this medication had on one of our primary outcomes here, which was the presence of these cumulative unique active lesions. These are all new lesions that an individual might have on a brain MRI. And what we see is that with the 10 milligrams, the median was 6 here, dropped to 1.4 average lesions in the 30, and down to 1.7 in the 45. So this demonstrated that the 10 perhaps didn't work that well, and it seemed that the 30 worked almost as well as the 45. So naturally, if you were looking at this medication, you would say, well, the appropriate dose that we should probably carry forward is the 30 milligram dose, right? It had almost as good effect as the 45, and it'll probably be better tolerated. The 10 seemed to be too low of a dose. We also decided, the authors of the study also decided to look at something called neurofilament, which is a marker that we can actually measure in blood that detects how much destruction there is of nerve cells. And what they found, very similarly, that there was a dose-dependent reduction. That is, the higher the dose was, the greater the decrease in this measure that marks destruction of nerve cells. So it appears that the medication works on this as well. So the conclusions of this study were that doses of 30 and 45 showed a strong effect on active lesions, that the 30 milligram dose was the lowest effective dose, and a phase 3 study is currently being planned. So this is a medication, so a phase 3 program will probably take another 4 or 5 years, depending on the duration of the trial. And so potentially, if that study is conducted and if it's positive, it's a medication that we might be able to see in the midterm future. A second study that I wanted to touch on was this MSC study. And so MSCs are something called mesenchymal stem cells. And this is by a company, it's called NeuroOwn. They make these stem cells. They take stem cells from the bone marrow of individuals with MS, they grow them in the lab, and then they can be given back to individuals. And these MSCs are autologous. That means they come from the same individual. They're taken from bone marrow, as I said, and they're induced to secrete factors that protect the brain, that protect nerve cells, and that potentially have effects also on the immune system. And what type of measures were they looking to see if these stem cells had an effect on? They were looking at spinal fluid measures. This vascular endothelial growth factor, which I'm going to call VEGF, which is basically a factor that protects cells. Also hepatocyte growth factor, which is a liver actually factor. It was initially discovered in liver, but it also has an effect on brain. And then NCAM1, which is an adhesion molecule that we think is related to progression. It was a phase 2 clinical trial once again. There was only 18 participants, and they got these neural stem cell, these mesenchymal stem cells, and it was given by lumbar puncture. So many times stem cells, we can inject them in the vein, or in the case of this study, we do a procedure very similar to a spinal tap, and we inject them in the spinal fluid of the patients. Why do we do that? Because we want these cells to get directly to the brain. We think there is some advantage for that. And then we collected their spinal fluid at 0, 8, and 16 weeks to see what type of effect these stem cells had on the patients. So these are the principal results of the study, and so you can see that these are all factors that we think are factors that are potentially protective in brains. And so you can see at week 0, this is before the patients got administered anything. And then you can start to see at week 8 and week 16 that after the individuals were given these stem cells, almost all the markers showed somewhat of an increase in these protective factors over time. This proof of concept indicates us that this medication is likely helping with brain protection measures. Now, once again, that has to be demonstrated clinically. We cannot rely just on these results. We have to make sure that we have a clinical study that examines something that's meaningful to patient. And this is basically just a graphical illustration of that same thing. It says how much each of those growth protection factors growed over time. And you can say especially VEGF increased quite significantly. All right, and now quickly I want to cover a third trial, which is the primary analysis of PROTECT-MS, which is a randomized placebo-controlled phase 2 study of a medication called temozolomab for the prevention of neurodegeneration in rituximab-treated patients with relapsing remitting multiple sclerosis. So I'll tell you a little bit about this very interesting compound. And why I wanted to highlight this is because this is actually affecting a pathway that we've really never thought of in multiple sclerosis. So there is an endogenous retrovirus. So this is a retrovirus that exists and has been implicated in the pathology of MS. It's called human endogenous retrovirus W. And we know that there has been development of medications that potentially can target a protein that is on the surface of this virus. And this medication is called temozolomab. And basically, it was studied in this phase 2 study. The primary outcome was safety, tolerability of varying doses of this medication, once again, illustrating the same process that we talked about. You can see that there was several secondary outcomes, and these were looking at things on MRI that we think would suggest that this medication would be helpful in individuals with MS. It included standard inclusion criteria for people with multiple sclerosis, and it excluded primary progressive patients with MS, patients 18 to 55 years. A little bit of a busy slide, but basically what the study showed is that there were no deaths, and adverse effects were frequent. However, none of these adverse effects were particularly severe. There were 2 only among all the adverse effects that we had that were considered severe. One was a hospitalization due to COVID, so that was in a patient who was treated with placebo, and one was a urinary tract infection. So somewhat of a signal, but something that we'll have to pay attention to. In terms of the clinical efficacy, there was only one suspected relapse in the study, and that occurred in the group that was treated with the temozolomab. And then we looked to see exploratorily if this helped improve or worsen the EDSS. And so you can see here, these are the 3 arms of the study. Very few events showing worsening at 48 weeks from baseline. Same for walking speed and same for hand function. So essentially, these are somewhat difficult to interpret, these results, but basically showed that the medication might have a suggestion of potential improvement. So with this, I would like to wrap it up. These are the 3 phase 2 studies that I wanted to present to you, and I think we are happy to move on to questions.
Thank you very much. Thank you very much. Are there any questions here in the Netherlands and Amsterdam? If so, please indicate, and there will be a microphone. It's over here in the middle.
Thank you. No, just thanks for the presentation. For the first and the third studies, how is the medication administered? Is it by oral or?
I believe it's an infusion for the last one, and for the first one, so the second one is oral medication. So the first is oral, and the last one is infusion.
Okay, thanks.
Yep.
Thank you for your nice presentation. I have a question about the second study with the mesenchymal stem cells. How often should these stem cells be administered to the patients to have a long-lasting effect? Because I can imagine that they sort of stop functioning or...
That's a fantastic question, and it's something that we've wrestled with in the field of stem cell therapy. There's different types of stem cell therapy. With this type of stem cell therapy, which is mesenchymal stem cells, the vast majority of studies have used a single dose. And long-term studies show that some of the measures that we study when we give these patients stem cells actually tend to go away over a period of time. However, the exact timing of what a subsequent dose of stem cells is required is currently not known. So I think the field's approach is let's test it, let's find a medication that has a very robust clinical effect, and then let's examine, follow those patients over time, and then we'll realize if disease activity comes back or if they start getting worse again, then that would be the idea that you would need to treat them again. But it's an ongoing area of research. Excellent question.
Yeah, because it is quite an invasive manner of administration, of course, via a lumbar puncture.
Yeah, that's correct. It is. It's a lot. Especially in the United States, we don't do very many spinal taps on our patients. And whenever we have studies that include spinal taps, we never can enroll patients because people don't like getting spinal taps. I believe in Europe it's a little more common. We did a study at the Cleveland Clinic with mesenchymal stem cells, and we actually gave them intravenously. And one of the concerns, we didn't see any major effects clinically in our patients. And always one of our overriding concerns was, well, what's happening to those cells? Those cells will be infused, and probably many of them will end up in our lungs. That's where things get washed out that are a little bit smaller. So the idea is, can we create some type of a radio tracer to determine where the cells are going? There's been some difficulty developing that, but I think if you could develop that, potentially you could give them peripherally and then expect that you could image to see if they were actually going to the brain or not, and for how long.
Thank you, Fu.
Daniel, there are 13 pages of questions
Okay.
from the audience that is connected, so that it won't be possible to go through all of them. But there are a number of them, of course, related to possible mechanisms of repair. So if you had to try to make a selection, which do you think are the candidates that have more possibilities to really reach this unmet need, which is currently brain repair or lesions repair?
Yeah, that's a great question. I think there's a couple of mechanisms that we can target in order to produce repair, and I think the one that makes most sense to us intuitively is something that will regrow back myelin. And that's not the only way I think we can do repair, but it's probably the principal one, or probably the most straightforward one. And so far we have clinical trial data from a single compound to do that, and that is clemistine fumarate. And clemistine fumarate is a medication that is, has been available for some time. It's a repurposed medication, which means it was used for something else, and now we're using it to produce remyelination. And there was a clinical trial that was done at the University of California, San Francisco, that examined this medication. And its primary, it was in individuals who had optic neuritis. And what they looked at was something called visual evoked potentials, which is an electrophysiological test. And what this medication showed is that it actually improved the measurement of how long it takes light to arrive from when it hits in the retina to when it goes back to the depth of the brain. And so this was a seminal study, because I think it was proof of concept showing that we actually could improve things. And now currently clemistine is under investigation as a medication in phase 3 trials of multiple sclerosis. Now, clemistine works on a pathway on an enzyme called CYP. And we think that CYP interferes with how lipids accumulate right before the production of myelin. And we think that how the cells that make myelin, called oligodendrocytes, use this enzyme is probably key in making sure that they have enough of those building blocks to rebuild myelin. So on top of clemistine fumarate, there are also several other medications that have been developed by several different pharmaceutical industries that are in the current planning phase of large phase 2 studies that will be examining medications that perhaps target this in an even more precise manner. So I think that, to me, if somebody would ask me what is the most likely direct pathway, I would probably say CYP modulation and medications such as clemistine fumarate. There was a study that I was actually going to present, which I actually decided not to because it was a negative study. And we've had several of these results. One of them was presented here at this meeting. I didn't present it because I think there's many of these medications that are tried and don't work, but it illustrates that this pathway to RMG1 did not work. And then, of course, many of you probably remember there was a very large clinical program for a medication that affects the LINGO pathway, which is a pathway that induces, that is involved in modulating how much myelination occurs, that regretfully was also negative. So yeah, I hope that answers the question.
You've just listened to part 1 of a 3-part series of October's live-streamed ECTRIMS 2022 event for people with MS. Thanks everyone for listening. Part 2 will be released shortly, so please stay tuned for updates. A special thanks to the European MS Platform and the MS International Federation for their contributions to this event. The event was held in English with simultaneous translation offered in the live stream in German, French, Spanish, Italian, and Dutch. And videos of all languages can be viewed on our YouTube channel. You could read more about this topic and more on our website, ectrims.eu. Do subscribe to the ECTRIMS podcast on Spotify and Apple, and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.